Good morning. My name is Dr. Veronica con Graversen. I'm going to talk about thrombosis and the eye, the dangers of a secret relationship. I have no conflict of interest. My goal today is to provide you with key points for clinical practice. First, I'll give you a summary of the vascular supply of the eye. I'll describe the most common systemic thrombosis with ocular involvement. I'll give you an overview of the spectrum of ocular disease. I'll talk about the retina and the risk of a stroke. And finally, we'll discuss COVID and its potential ocular manifestations. Let's start. The connection of the eye with the rest of the body is fascinating. Imagine that almost 50% of the brain is involved in visual processing. 70% of all your sensory receptors are located in your eyes. And because the vasculature of the eye and the heart share several characteristics, it is possible to determine accurately the risk of cardiovascular events just by looking inside of your eyes. If we review the ocular blood supply, we'll find out that the ophthalmic artery and its branches are the main source of the ocular blood flow. For the purpose of this talk, we'll focus on the posterior segment of the eye, with the central retinal artery and the posterior ciliary arteries. The central retinal artery perfuses blood to the inner retina, and the posterior ciliary arteries provides blood flow to the outer retina, including the photoreceptors, by diffusion from the choriocapillaries. But how does this work? It works because the ocular circulation is unique and complex. It involves the two vascular systems that I just mentioned, the retina and the uveal system. The retina is one of the highest energy demand tissues in the body and has a high oxygen consumption. And as a consequence of these unusual energy requirements, retinal cells are exquisitely sensitive to disturbances in the energy supply, so they are autoregulated. The choroid, on the other hand, has the highest blood flow per unit weight of any tissue and has a great density of autonomic innervation with main regulators such as vascular endothelial cells and neural cells. Since the eye is the only organ that allows us to examine directly its blood vessels, ophthalmologists, we dilate the iris, we open the pupil, and we are able to evaluate the fundus of the eye. Nevertheless, paying attention to the clinical history is of paramount importance. A careful past medical history during an eye exam could provide the clues linking the eye with a systemic disease. These are the most common pathologies associated with eye thrombosis. Ocular ischemic syndrome and venous stasis retinopathy can present with central retinal vein occlusion, hyphema, or signs of inflammation in the eye. It's important to evaluate for carotid disease. Cogan syndrome can be typical or atypical. Typical cases show interstitial keratitis, but atypical ones can present a broad range of manifestations, including vasculitis and thrombosis in the eye. We need to rule out hearing loss and signs of systemic vasculitis. With antiphospholipid syndrome, the patients can show vascular occlusions in the arterial or venous system, and we need to investigate if the patient has had previous miscarriages. Sussex syndrome involved arterial occlusions in the retina, the central nervous system, and affection of the cochlea. Sarcoid can be a masquerader, and in the eye it shows vasculitis or granulomatous uveitis, but it's important to evaluate the lungs and the brain as well. Systemic lupus can show cotton wool spots, uveitis, or occlusive vasculitis in the eye. The occlusive vasculitis is of particular importance because of the higher morbidity and mortality representing involvement of the brain or the kidneys. Fibrous muscular dysplasia can show or can manifest with vascular occlusions, and it's important to evaluate the kidneys to rule this out. Central nervous system lymphoma can show vascular occlusion and uveitis. Patients with history of replacement of cardiac valves are at particular risk of endocarditis and may present with branch retinal artery occlusions. Therefore, the past medical history is crucial as well as performing an echocardiogram. Dural sinus thrombosis Patients may show papilledema and nerve palsies, and in cavernous sinus thrombosis, we are going to be able to see venous tortuosity, central retinal vein occlusion, and proptosis. It's relevant to determine the appropriate treatment at the time of diagnosis. In cases of giant cell arteritis, we may see a pallid optic nerve edema, visual loss that is rapidly progressing, and sometimes you can see a central retinal vein occlusion combined with a branch retinal artery occlusion in the same eye. In these cases, we need to send for sedimentation rate, which is usually elevated, as well as CRP and thrombocytosis. Patients like these usually require a temporal artery biopsy. But what is the spectrum of ocular disease? Arterial and venous circulation can be affected. If the arterial system is compromised, the manifestations can range from a central retinal artery occlusion with a cherry red spot, a branch retinal artery occlusion and a localized whitening of the retina, a plaque that could be a cholesterol plaque or a fibrin or calcified plaque, a cotton wool spot that it represents an infarct of the nerve fiber layer, paracentral acute middle maculopathy showing some ischemia from the retinal capillaries. When the arterial and venous systems are compromised, you can see central retinal vein occlusions and branch retinal artery occlusion in the same eye. If the veins are affected, the range of manifestations can be from a hemiretinal vein occlusion, a central retinal vein occlusion usually involving the optic nerve, or the branch retinal vein occlusion. What is their common characteristic? That they may threaten vision and sometimes your life. Now let's talk about retina and the risk of stroke. An acute arterial retinal ischemic event reflects impaired blood flow in the anterior cerebral and ocular circulation. It was established that a central nervous system stroke is a brain, spinal cord, or retinal cell death attributable to ischemia. Patients may complain of transient visual loss that is painless, with symptoms that last few minutes but not more than 60 or 90 minutes on average. Usually also they complain of negative symptoms, so there is no history of flashes or floaters. Most likely this is due to the streaming effect of the smaller vasculature. The types of affections are a retinal TIA, a branch retinal artery occlusion, or a central retinal artery occlusion. Why this is important? Because of the high risk of cerebrovascular and cardiovascular events. Because it carries almost the same poor vascular prognosis as cerebral ischemia. And studies have shown that a treatment is often delayed with retinal TIAs occur. A report also showed that 25% of cases with acute retinal ischemia had acute brain infarctions on MRI. And the risk of a stroke is maximum within the first few days after the onset of visual loss. So prompt diagnosis and triage are mandatory. Finally, let's discuss about COVID and the eye. COVID can invade many organs of the body with widespread tissue damage and endothelial injury. Superposed inflammation will induce further endothelial damage with secondary decreased production of anticoagulants. In fact, preliminary clinical data from COVID patients point to a prothrombotic state, suggesting three possible mechanisms. First, the virus affecting cells can alter the immune response of natural killers and CD8s, enhancing endothelial dysfunction and apoptosis. The second postulated mechanism is microvascular immunothrombosis. But what is this? Well, under certain inflammatory conditions, platelets, neutrophils, and some coagulation cascade like fibrin team up to contain invading pathogens. However, a dysregulated response may aggravate tissue damage by triggering thrombus formation, vessel occlusion, and hypoxia. In these cases, CD177 marker has been found highly upregulated. The third mechanism involves secondary hemophagocytic lymphohistiocytosis. The cytokine storm with macrophage activation and multi-organ dysfunction where cytokines are secreted by activated leukocytes and endothelial cells. Cytokines are procoagulant and they produce interleukin 6 and TNF alpha, and their signaling is enhanced by thrombin generation. So these pro-inflammatory cytokines destabilize the atherosclerotic plaques by promoting cell apoptosis. That, in addition with demand ischemia, vasospasm, and endothelial injury, is a recipe for disaster. These turn into a vicious cycle with extensive endothelial injury being similar to what diabetes does to the retina. Therefore, the potential manifestations are central retinal artery occlusion, central retina vein occlusion, optic nerve edema, retinal hemorrhages and rod spots, macular edema, cotton wool spots, and uveitis. But what is the future? The future is further research to validate these potential manifestations. And most importantly, for ophthalmologists is to remember that patients with retinal TIAs require referral to a stroke center. It's important to evaluate the patient in detail to determine the true nature of an ischemic event. And for physicians in general, please never underestimate the diagnostic clues of an eye exam. Thank you very much for the invitation and for your attention.